Because this is educational session, I decided to talk a little bit about our thinking behind the models that we are working with and thinking of modelers in radiation oncology. So what is modeling outcomes about? It's about combining the information about the treatment, which can be quite complex, with information about the patient treated, to say something quantitative about possible outcomes of this treatment. And I just listed an example of a few possible outcomes or endpoints that we are interested in. And as I said, the treatment in itself can be quite complicated. It may be, in addition to radiation therapy, combination with surgery, chemo, gene therapy, and others. Generally, in the modeling world, there are two thoughts of thinking. Some people say that it is possible to develop models based on principles. So those are mechanistically based models. And the proponents of those say that mechanistically based models have better cognitive and predictive potential. This is true if the model that you have is correct. In other words, if it describes the underlying biology or mechanisms correctly. If it's not, then it's not true. So people who prefer data-based or empirical models, they say that those models, data-based models or empirical models, they have better practical value because of the infinite complexity of the underlying phenomena. And many people say that indeed the underlying biology is infinitely complex. So to have a model that is correct in biological sense, you would need infinite number of parameters. The consequences of incomplete model are very severe, that your model parameters that you estimate from the data can be awfully biased. So again, giving you a very incorrect model. So in my opinion, there are no purely empirical or purely mechanistic models, because this distinction, in my opinion, is only relative. It depends on the component of the biology or mechanisms in the model versus how much is in it from simply observation or phenomenology. The fundamental, in my opinion, concept in modeling outcomes is the concept of tolerance. And you probably hear it quite often, and often in the definition that people use is, in my opinion, incorrect. If you look at the definition of tolerance, if you Google it, you will see several variants of it. But the one that I think applies in radiation oncology would be this one. The tolerance is the capacity of an organ or organism to tolerate unfavorable environmental conditions. In cancer treatment, those unfavorable environmental conditions are caused by our treatment, by radiation. So that's the phenomenological definition of tolerance. And it's fairly reasonable to assume that in a patient population, there will be patients with very high tolerance. There will be a few patients with very low tolerance, but most of the patients will be somewhere in between. So even if you think of in terms of central limit theorem, you can come out with a conclusion that the distribution of tolerance in a population of patients should be more or less bell-shaped, like this one. The other concept that is often used, and again, in my opinion, often incorrectly, is the tolerance dose. The definition that I like is that the tolerance dose is the largest quantity of a substance, either radiation dose or chemo dose, if it's a drug, that an organism or organ can endure without exhibiting unfavorable or injurious effects. So this definition tells you that tolerance dose is the threshold dose. If you exceed this threshold dose, something will happen. if the dose is below this tolerance dose, nothing will happen. You can, of course, only tell whether this tolerance dose was exceeded for a given patient if you observe the effect. If patient is locally controlled, then you can say that tolerance dose of the tumor was actually exceeded, because this concept of tolerance and the concept of tolerance dose equally applies to tumors as to normal tissues. And in the whole my presentation, everything I will say will apply to both tumors and normal tissues. So if patient is locally controlled, you may say the tolerance of the tumor was exceeded. If patient exhibits, let's say, grade 2 pneumonitis, it means that the tolerance dose for grade 2 pneumonitis was exceeded. So it's a binary effect even for endpoints that are not binary, that are, let's say, graded. Because, as I said, you can always have different tolerance dose for grade 2, grade 3, grade 4, or whatever. Even for outcomes, say, for parotid gland, if your endpoint is percent of produced saliva, this can be also discretized, and you can say, okay, do the patient have saliva production above 25% of the normal level or below? That's your threshold, and associated with it, your threshold dose. So it's obvious that this is fairly complicated. But what's more complicated than description of our treatment is actually description of the biological system that we deal with. It doesn't mean that the model of outcome needs to be complicated, and I will demonstrate it. So before I show the distribution of tolerance, now I quantify it in terms of tolerance dose. So again, there will be patients with very high tolerance dose, very low tolerance dose, and majority will be somewhere in between. So the distribution of tolerance dose will be bell-shaped. You can present this distribution in cumulative fashion. So the cumulative distribution of tolerance dose, if the underlying distribution of tolerance is bell-shaped, will be S-shaped. It's just a consequence of the assumption that there's more patients with tolerance, around the average, and fewer patients with very high tolerance or very low tolerance. So that's the origin of the S-shaped cumulative tolerance distribution. So how we quantify it? Oh, one more thing. You often hear about dose response. So what is this dose response? Well, so far I told you that there is distribution of tolerance in the patient population. This has nothing to do with treatment. This is potential tolerance distribution, whether you apply a treatment to any particular patient or not. That's something that exists. Now, let's say you have a patient, and from your general population of patients, the only thing you know about this patient, that this patient is it's a random sample from the population of patients. And let's say you apply this dose to this patient. You want to know what's the probability of an outcome for this patient. Well, it relates directly to the shape and position and the distribution of tolerance in the population of patients. Because, okay, if you apply this dose, this treatment dose, and you superimpose this on the distribution of tolerance in the patient population, you will see that about, let's say, 75% of patients have tolerance dose less than the treatment dose that you are considering. So what it means? That there is 75% chance that this patient has tolerance lower than your treatment dose. So in other words, there is 75% chance that this dose will be exceeded. So the patient will exhibit the outcome of interest. That's how treatment dose relates to the distribution of tolerance in the patient population. And that if you do this for different treatment doses, you will get the dose response, which is identical mathematically and in shape to the distribution of tolerance. So how you quantify it? If I assume that this bell-shaped has normal distribution, that's the mathematical function that describe it. And again, what's my cumulative form? That's just the integral of this probability density function. This is the mathematics behind the Lyman model that Alan was talking about. So the probability of observing an outcome for a given dose, treatment dose that you apply, is calculated using this function. Again, I would like to emphasize that this all applies to both tumors and normal tissues. There's no difference, really. However, there is another distribution that is very similar to normal distribution, logistic distribution, and this is the mathematical formula that describes this distribution, that has advantages over normal distribution. The shape, as I said, is very similar. Logistic distribution has somewhat heavier tails. But what's the advantage of logistic distribution versus normal used in the Lyman model? The advantage is that this integral can be actually calculated, and there's closed form solution to this integral. And this is the solution of this integral using as a PDF logistic function. So, this function, if you compare this with the Lyman model, in other words, with the actual integral of the normal probability density function, you will not distinguish those two. In other words, this dose response function and the Lyman based on normal distribution function, they will be not distinguishable using any clinical data set that you may find. Because by using simulations, you can tell that it would require at least about 10,000 patients, with about half of them experiencing endpoints, to tell that one function, let's say, normal function fits the data, the other one does not. In other words, one is consistent with the data, the other one is not. So there's really no advantage if you use the Lyman model to use the normal approximation and use the integral to calculate the probability of complication. You can use this function and you will get exactly the same results. Tolerance in a population is often, in my opinion, not bell-shaped, but actually logarithm of tolerance is probably bell-shaped, because tolerance cannot be less than 0, and probably there are some patients with extremely high tolerance. So the distribution of tolerance is a little bit skewed. So probably log normal or log logistic distribution is more likely to be true. If we assume that tolerance dose or X is logistic distributed, then we'll get this form of the response function. And using commonly used parameters, D50, the dose that gives 50% probability, and slope gamma 50, that's the model for probability of response. And again, this is the model that equally applies to normal tissues and tumors. So it's important to remember, if you use this model, those parameters, D50 and gamma 50, are parameters describing the distribution of tolerance for a given endpoint, for a given population of patients. D is the variable describing treatment. Also, the advantage of this formulation is that it's a ratio. So whatever units you use for D, you should use for D50. Or how you describe tolerance, you should use exactly the same form to describe your treatment. You see, I say treatment, not just dose, because it's more complicated than that. Because we all know that response depends on several treatment and patients' characteristics. Of course, it depends on fractionation, on spatial dose heterogeneity. Let's say it depends on hypoxia, several risk factors as well. You apply the same dose distribution to different patients, and they may respond differently, not just because of random effects, but because they differ in terms of age, let's say gender, race, smoking, etc., etc. So how you account for all of this in our logistic response model? Well, this is just an example. Let's say that smoking matters for our endpoint of interest. So maybe the distribution of tolerance that we have actually consists of sub-distributions for different distribution for smokers and different distribution for non-smokers. You see that those distributions, if we stratified population into smokers and non-smokers, those distributions will be narrower. In turn, the slope of the dose response curves for smokers and non-smokers separately will be steeper. If it's steeper, it's better defined. Probability of any outcome will be easier to determine. So this is just an example of smokers and for non-smokers. So how we account for it, let's say for smoking in our response model? Well, you can say, for example, based on the data, clinical data, that average tolerance of smokers is half the tolerance of non-smokers. Okay, so D50, which describes the position of the tolerance, will be half. So you multiply it by 0.5. But it's a matter of interpretation. You can say, okay, but instead of renormalizing tolerance, I calculate effective dose. So you can say effective dose for an average smoker is twice the dose for an average non-smoker. So you multiply this by 2. Mathematically, it's exactly the same, but you interpret it completely differently. Here you say, okay, I readjust my tolerance dose to account for smoking. Here you say, I adjust my treatment, my dose, to account for the fact that the guy that I'm treating is a smoker. The same for other facts. Let's say dose per fraction. You can say, okay, I adjust the tolerance dose to current dose per fraction if it's different. Let's say you're using 3 gray per fraction and you want to know in terms of 2 gray per fraction what it is. So your reference dose per fraction would be 2 gray. So you can use your favorite, let's say, LQ model, and that's based on the LQ model. You adjust tolerance dose. So you change the dose D50 as a function of dose per fraction. But again, you can do the same by adjusting dose to the current dose per fraction. It doesn't matter because you can tell this is just reverse of one of the other. It's mathematically exactly the same. It doesn't matter how you interpret it, if you're by adjusting dose or adjusting the tolerance or adjusting dose. It gives you the same result. And of course, we know as physicists that dose is not really dose when we treat patients. We treat with dose distributions. So what we do about those distributions? How you account for dose inhomogeneity or for volumetric dose distribution? You may have heard about the concept of equivalent uniform dose. We proposed this concept about probably 15 years ago already, and that's the formula. It's very similar to the formula in the Lyman-Cutcher-Borman model, but the origin is completely different. Remember that in the Lyman-Cutcher-Borman model, what was proposed is that tolerance as a function of partial volume irradiation changes as a power of volume. This formula has no volume at all in it. It assumes that for each voxel, the sum is, by the way, over voxels of your structure of interest. It assumes that local effect that is important for the outcome of interest is some power function of local dose. There is no volume at all in this formula. So what is this? So that would be the logistic response model that accounts for dose inhomogeneity or for actual dose distribution. So what is this EUD? EUD was defined as that dose which, if applied uniformly to the whole structure or organ, would lead to the same clinical consequences as would be obtained using the non-uniform dose distribution of interest. So remember that this means that you simply substitute your non-uniform dose distribution with perfectly uniform dose distribution, subject to all other conditions being exactly the same. So using the same fractionation, or in other words, the same number of fractions, the same total dose, it's the same patient. So you don't have to account for anything else. You don't have to account for dose per fraction. You don't have to account for, let's say, oxygenation, because it's the same organ, the same patient. So let me illustrate this. Let's say I have a dose distribution that half of my structure gets 60 gray, half gets 45 gray, and 30 fractions. And the same dose distribution in 20 fractions. So the dose volume histogram, in terms of physical dose, is exactly the same. So if I calculate EUD, assuming that parameter A, which is different for different structures and for different endpoints, is 3, I'll get about 54 gray. So that's the equivalent dose for this dose distribution. For this one, of course, it's 54 gray. It's the same because I just calculated the equivalent uniform dose. What's different is this is 54 gray delivered in 30 fractions. This is 54 gray delivered in 20 fractions. So, of course, the effect will be different. So let's say you want to know, okay, I want to know how much this dose is in terms of 30 fractions. It's easy actually to calculate. Again, using your favorite LQ model, you calculate what's the equivalent uniform dose from this dose distribution if I deliver it in 30 fractions. So based on the LQ model, it's about 67 gray. So this dose distribution is given in 20 fractions, is equivalent to 67 gray delivered perfectly uniformly in 30 fractions. So my correction factor, you may call it, it's about 1.24. You can do the opposite. You may want to know what's this dose distribution in 30 fractions worth in terms of 20 fractions. And the calculation is very similar. It's 44 gray. So this distribution in 30 fractions is worth about 44 gray delivered in 20 fractions perfectly uniformly. So you can see right now, probably you can sense how I propose to account for all those factors that are important for outcome. We use this simple formula, again, both for tumors and for normal tissues. And the whole point is how to calculate this correction factor. And again, you can either say, okay, I'm correcting tolerance dose, or you can say, I renormalize my dose. It doesn't matter. There are good arguments that this correction factor, if you need to correct for, let's say, all those parameters, should be has a multiplicative form, which each correction factor corresponds to, let's say, dose per fraction, gender, genetic profile, however you want to describe it, age or whatever. And so the whole research in radiobiology as applied to modeling outcomes is actually how to get the functional form of those Fs and how to get the parameters of those Fs. And then you simply apply it to this formula. So technically, if you know those parameters and those functions, that should be simple. This is a very simple calculation. It's almost a back-of-an-envelope calculation. So in my closing remarks would be that the biology of tumors and normal tissues is too complex to allow biological or mechanistic modeling of radiation therapy outcomes from first principle. In my opinion, that's impossible. The outcomes depend on several known and unknown and possibly unknowable factors in nonlinear fashion. This is actually very important, nonlinearity, because this nonlinearity of response to treatment, coupled with incompleteness of our models of outcomes, may cause serious bias in estimates of model parameters and their errors. This is serious because if you are a fancy modeler, you fit the clinical data that you have with your model, and you are advanced modelers, you also estimate confidence intervals for your model parameters. And if your model is incomplete, and it's always incomplete, then the estimates of your errors will be awfully biased. In other words, the true value of your parameter may be way outside even 99% confidence intervals of your parameters. So this is a little bit scary, and that's why I'm very skeptical when I see parameter estimates in papers given with the error bars, because I'm pretty sure that those parameters are biased. Better outcomes of radiation therapy will strongly depend on treatment individualization or optimization made possible by more reliable models of outcomes. I think that's absolutely necessary. If we want to make improvements in our patients' outcomes, we need models of outcomes that will drive us in the right direction, how to make it better. And models of outcomes need to combine data-driven phenomenology with radiobiological considerations. The model, the logistic response model that I showed you, can easily combine those two. And it's important to remember that the ultimate measure of models' usefulness is the level of agreement of the model's predictions with a wide range of the corresponding clinical data. And I think that's the last slide. Okay, thank you very much. So if there are any questions to me or to Ellen, yes, please.
What's the current thought now on how one incorporates the previous treatment?
Well, we don't have good models for this, but in fact, it is in terms of methodology. The model should be actually fairly easy because you can use the same model. You simply need to adjust tolerance for this patient for retreatment. If the patient was treated, let's say 5 years ago, for prostate using external beams, and then there is local recurrence and you have to do something about it, you know that the tolerance for this patient is probably somewhat lower for the normal tissues. But the functional form of the tolerance distribution will be exactly the same. The dose-response shape will be exactly the same. The only thing you need to know is how to adjust the tolerance. The only way to know it is to actually analyze the clinical data. There's no other way around it.
And does that clinical data exist? Is there some kind of consensus? Where do we go?
Well, I'm involved in analyzing some retreatment data for prostate patients in Spain. And so far, the patient actually, the time between the treatment and retreatment is actually more than 5 years. It's on average about 10 years. And so far, I don't see any difference in complication rates after if retreatment is more than 10 years after. It's a small sample of patients. It's 50-something patients. But obviously, it depends on the time interval between the initial treatment and the next treatment. But the data is very, very limited. But as I said, I don't believe you can derive this correction factor for tolerance from radiobiological considerations. No matter how sophisticated you are in molecular biology or genetics, I don't think you will be able to tell me, the tolerance after 5 years should be 70% of the initial tolerance, and after 10 years it's 85%. There's no way. The only way to find out is by analyzing, using proper models and proper techniques to analyze the outcomes, the clinical data.
Come up to the microphone because they're recording.
One of the parameters that you mentioned there is using in your models the alpha-beta ratios. And that information is being always questioned about how reliable those values are. And obviously they will depend on different organs. Is some of your methodology likely to come back and help you determine those ratios better?
Right. As I mentioned, the model that I show it can be a combination of both data-driven functions and parameters and biology-driven. The LQ, well, you as a good starting point is to use the alpha-beta ratio from, let's say, cell survival experiments. Now, the people who do cell survival experiments will tell you that their estimates of alpha-beta ratio are fairly correct. But the ultimate test, of course, is to feed the model with alpha-beta ratio as a parameter to the clinical data, and then, using whatever maximum likelihood method, estimate the alpha-beta ratio from the clinical data. That way, you say, okay, that's the real alpha-beta ratio applied to my model, applied to the derived from the population of patients of interest. It may have nothing to do with alpha-beta ratio of cells, of surviving cells. It may, and in fact, that's my belief that the alpha-beta ratios for clinical endpoints will be very different for alpha-beta ratios from cell survival experiments.
Hi, the ICRU is proposing a dose iso-effective E, a dose iso-effective, with weighting factors of W's, which apparently are similar to your F's. Are you familiar with this and have any comment on that?
Which ICRU report? Which one?
Well, it's come out in radiation dosimetry, so it's called dose iso-E.
Well, I have to admit I'm not aware of it. Are you? No?
Okay.
But presumably, I guess I would just say if these are driven by studies of the outcomes for a particular effect, they may tie in. We would both, I think, have to look at the...
It's remarkably similar, so I guess we have to marry these efforts across the world here.
Well, that's great. If it's remarkably similar, I'm happy. Yes, please.
Can I just make one more comment? When you are addressing the previous physicist question, you said we can use clinical data, fit into it, and derive the alpha-beta ratio. Do you assuming the N and M will be fixed because there will be more variables? Usually we're doing another way. Alpha-beta is assumed we know, and then we derive N and M from the clinical data. But if you want to also derive alpha-beta ratio, then you have to assume the N or M maybe is fixed. Is that right?
Yeah, well, what you can derive from the data depends on the richness of the data. Okay, if you have very large data set and a lot of endpoints or cases with that actually something happened, you can calculate more parameters. And there are, in modeling and statistics, there are good rules how many you need actually, and you need about 10 events per parameter. So if you analyze the data and let's say you have 30 local failures out of, let's say, 100 patients, then you can afford to fit a model with about three parameters. Well, if it's exploratory analysis, maybe 4 parameters, but not more. If you have a data set and you have only, let's say, 2 myelopathy cases, there's nothing you can tell about the parameter of the model that predicts probability of spinal cord damage. It's just not enough data.
Okay, thank you.
You're welcome. Okay. Thank you very much.